Yes.
So લગભગ સ્ટાર્ટ કરીને છે ને 5:15 પછી નીકળી જઈશ, તો તમે પાછળનું બાકીનું તમે જોઈ લેજો.
Okay.
કિરીટભાઈ he joining હા કિન્નરી વાળાનો નંબર મારી પાસે લગભગ નથી છે. જોઈન કરી
નથી આવ્યા. હા મેડમ આવી ગયા છે.
મેડમે નેહાલ મેડમે લિંક મોકલી આપી છે બધાને.
ગુડ ઇવનિંગ કિન્નરી મેડમ.
મને બી જરા મોબાઈલ થી જોઈન છું ભાઈ.
ના કઈ વાંધો નહીં સર.
Good evening, everyone. Good evening.
ગુડ ઇવનિંગ મેડમ.
મેડમ વિડિયો ચાલુ કરો એન્ડ બીજા કોઈનું યુઝરનેમ કરવાનું તો કરાવી દે. ઓલગ ઇઝ ધેર મયંક. ચલો લેટ અસ સ્ટાર્ટ. તો આવશે સુધી.
Batul, we can start the session.
So with all your due permission, we are beginning with the session for today. Good evening, everyone. I am Batul from Clearnet. I would like to take a minute to introduce our platform Clearnet to everyone present here with us today. Clearnet is India's one of the largest digital live CME platform where doctors generate their medical content. I would like to welcome all the esteemed speaker doctor and the participant doctors in today's live digital monthly CME that is organized by Academy of Paediatrics, Gujarat. The webinar in association with the Academy of Paediatrics, Gujarat has organized a case-based discussion on the abdominal system. Team Clearnet is happy and proud to be the digital partner for this webinar. Please have a glimpse on the video that is going to be played. Now, without any further delay, I would like to welcome Dr. Kirit Sisodia, sir. Sir, without any further delay, I'm handing it over to you. You can proceed from here.
Thank you, Batul, for kind introduction. I welcome all the dignitaries, Dr. Yogesh, Dr. Palak madam, Dr. Kinnari madam, and all the students on behalf of Academy of Paediatrics Gujarat. Today, in a session of Academy of Paediatrics Gujarat E-Gurukul PG Clinic, We are going to discuss the case discussion on the alimentary system. And for that, today with us, we have our mentor, Dr. Palak Hapani, madam. So, madam is Associate Professor at PDU Medical College, Rajkot. And with that, ma'am, we have a student that is Shreya Mistry with us. Today, we have two mentors with us on this case discussion. Dr. Kinnari Vala, madam. Dr. Kinnari madam is Associate Professor at the Department of Pediatric Nephrology and Kidney Transplant Unit, IKDRC, at Ahmedabad. She has completed the post-graduation and then done fellowship in Pediatric Nephrology from the Maharashtra University, done fellowship in International Pediatric Nephrology Association and fellow of Indian Society of Pediatric Nephrology. Madam having a special interest in pediatric kidney transplant as well as infection, growth and bone sensitization patient and APMR. Clinical pediatric nephrology, she is working at the IKDRC. So our second expert for today's session is Dr. Sudhir Reddy. Dr. Sudhir is pediatric nephrology at the Guntur Medical College, Andhra Pradesh, and is a consultant pediatric nephrology at Blossom Children's Hospital, Guntur and Vijayawada. Sir has completed their MD, MBBS and MD for Andhra Pradesh and done fellowship in pediatric nephrology from CMC Vellore and done their short clinical pediatric nephrology fellowship from Germany. Sir is affiliated with government councils and many professional bodies and societies. And sir has presented many research papers in national as well as international journal. So now, without delaying, I will request our today's student Shreya to start the session with this discussion, and request Dr. Palak madam to mentor her. Thank you.
Good evening, everyone. I myself, Dr. Shreya Mistry, third year resident doctor at PDU Medical College, Rajkot. I am going to present a case on alimentary system under guidance of Dr. Palak Hapani, Associate Professor at Pediatric Department of PDU Medical College, Rajkot.
Dr. Shreya, let me hear how to going on. First of all, we miss the Dr. Baldev Prajapati sir's as a moderator. So today, Dr. Palak will moderate the session, and both the experts, Dr. Kinnari and Dr. Sudhir Reddy, will ask the questions and their expertise.
Okay.
You have to start with the small history, then part before the examination, then the general examination and the systemic examination, then whatever the investigation, then the management. So first of all, you have to concentrate on the first part of the summarize the history. Okay, go ahead. Please go ahead, Doctor.
General information. Informant being a mother of the patient Rekha Ben. So patient is Chanda Ben Ramesh Bhai Thakur, 8 years old female, Hindu female child, born out of non-consanguineous marriage, residing at Jetpur, Rajkot, belongs to lower socio-economical class according to modified Kupuswamy method, present into PDU Medical College and Hospital Rajkot, with being referred from Civil Hospital Junagadh with the chief complaints of the whole body edema since last 15 days.
Just a minute. Shreya, keep your mobile in horizontal position so screen would be more proper.
Okay.
Yeah, thank you.
Better to join with the laptop. I am trying also.
Fine. Now screen is visible there.
The chief complaints being whole body edema since last 15 days, decreased urine output since last 10 days, abdominal distension since last 10 days, and convulsion since last 1 day. History of presenting illness. Patient was absolutely asymptomatic before 15 days. Then patient had puffiness of bilateral eyes and periorbital edema noticed by mother since last 15 days. The edema was more in the morning when child wakes up and gradually decrease at the end of the day. Edema then progressed to bilateral upper limb and then to bilateral lower limb since last 10 days. There was associated swelling with external genitals noted by mother since last 8 days. Decreased urine output and dark color urine since last 10 days without any pain, and the dark color of the urine presented throughout the stream before 10 days. Pre-illness frequency was of urine was 6 to 7 times a day, that gradually decreased to 3 to 4 times a day and decreased in amount. Abdominal distension since last 10 days, there was no pain in the abdomen. Patient was having convulsion in the form of abnormal movement of the right upper limb with uprolling of eyeballs lasting for 10 to 15 minutes before 1 day. There is no associated frothing from the mouth or involuntary passage of urine or stool. There is no any pre-ictal aura or post-ictal headache or blurring of vision, and no loss of consciousness, and convulsion subsided by some IV drugs. 3 such episodes in 2 hours, and the patient was conscious in between convulsions. Negative history. There was no any complaint of bleeding from any side, no any icterus, no tremors and ultrasensorium. There was no history of fever or sore throat. There was no abdominal pain, no history of loss of appetite, loss of weight or irritability. There was no history of joint pain, drug intake or fever with rashes or skin lesion. There was no history of burning micturition, urgency or dribbling of urine. There was no history of headache, blurring of vision, trauma or facial weakness. There was no history of breathlessness on exertion, chest pain, paroxysmal nocturnal dyspnea or palpitation. There was no pallor or no constipation. Past history. There was no any past history of similar illness, no any past history of hypertension, diabetes, tuberculosis, asthma or convulsion, no any history of blood transfusion or any drug intake or drug reactions, no any past history of hospitalization. Treatment history. Patient was admitted at civil hospital, Junagadh for 5 days. Investigation done for whole edema and decreased urine output and abdominal distension, suggestive of presence of proteinuria and hypoalbuminemia. Patient was started on oral medication which has to be taken for total 3 months as explained by relatives. Patient was not improved and edema increased. Patient had 3 episodes of right upper limb focal convulsion, so patient referred to PDU Medical Rajkot for further management. Family history. There was no any family history of the similar illness, no any family history of hypertension, diabetes, tuberculosis, asthma or convulsion, no any family history of blood transfusion. Personal history. Eating habits of the patient's appetite was adequate and patient was on mixed diet. Interactions with other decreased since last 12 days. Sleep was adequate. Bowel frequency unaltered, and bladder frequency decreased urine output since last 15 days. Antenatal history. The mother was 4th gravida, 4th para, book pregnancy with any uneventful antenatal period. Birth history. Patient was born with the normal vaginal delivery at private hospital at full term with the birth weight of 2.2 kg. Cried immediately after birth, no any requirement of resuscitation, no history of any NICU admission. Immunization history. No any recall or document available by mother, but BCG scar was present on left arm that suggests the patient was partially vaccinated. Family history. Family was nuclear family. Total family members were 5. Father's age was 32 years. Mother's age is 30 years. Patient was brought out of non-contiguous marriage. Father's occupation was laborer in farm and mother was housewife. Literacy of father is 7th standard and mother was studied till 3rd standard. Pedigree. Mother is 30 years, father 32 years old, and there was a history of two siblings expiry. One sibling expired at first day of life due to birth asphyxia. Another male sibling expired at the age of 1.5 year due to pneumonia with the severe acute malnutrition. The patient has another sibling, which is a female, 10 years old, and another younger sibling, which is 6 years, male child. Developmental history. All developmental milestones achieved till age. Patient is school going at village level government school, studying in the 4th standard and was average in study. Social and environmental history. Per capita income was 2,000 rupees per person per month as described by father and mother. Housing condition. The patient was living in kacha house. The water source is well water and open sewage disposable. Diet history. At birth, no any prelactial feeds given and patient was breastfed within 1 hour of birth. Exclusive breastfeeding continued till 7 months of age, including 6 to 7 times in a daytime and 2 to 3 times in a night. Complementary feeding was started at the 7 months of age with dal water, milk, biscuit, khichdi, mashed roti, and with continued breastfeeding. Currently, the patient is taking homemade foods 3 times a day. The 24-hour calorie intake is 1800 kilocalorie per day and 28 gram per day protein in pre-illness state. Now I would like to proceed for the further general examination.
Shreya,
Yes.
Dr. Shreya, hello. Now you have to summarize the this whole history part before the examination. We are proceeding for the general examination.
Okay. So the patient was having the patient is 8 years old female child and born out of non-consanguineous marriage. No any significant past history. Presented with the complaint of decreased urine output, abdominal distension, and whole body edema, which has started from the face and gradually developed in upper arm and then upper limb and then progressed to lower limb with genital edema. So I would like to proceed further for the general examination of the patient in a view of to rule out any cause in view of anasarca, that is whole body swelling.
Based on history, what are you suspecting?
Based on history, there is a one possibility of any renal system involvement, that is edema, decreased urine output, and
Dr. Shreya, this is the short history and the first episode. Because
yes.
you mentioned about the edema and the decreased urine output since only the 10 days, and the history of conversion for 1 day only one episode. First, and then patient referred from Junagadh to PDU Rajkot. Okay. Hello.
Yes.
Yeah. Hello. So before going to the directly to the renal system or the kidney involvement, can you summarize what are the possibilities before this causes of the edema and the decreased urine output involving the other systems?
So there is one possibility of involvement of the renal system and another is CNS system involvement. So it can be multi-system involvement. So it can be metabolic disturbance, which has led to renal system failure and subsequently any dyselectrolytemia leads to development of convulsion. Then another one is nephrotic syndrome that may be presented with the convulsion like complications like convulsion. It can be nephritic syndrome. which is presented with the associated complications like convulsion. It may be cerebral and renal vein thrombosis and associated hepatorenal syndrome or oculocerebellar renal syndrome that can be presented with the similar complaints.
And you have mentioned in the negative history the whole abdomen pain and the drug reaction and the joint pain. So, what is in your mind uh, while you are asking this negative history, one by one?
So while asking negative history, I am trying to rule out any other system involvement.
Yeah, yeah. We want to know that only, please.
So by no any complaint of bleeding from any site and no any icterus, tremors or altered sensorium, we can rule out any liver disorder that will be associated with any bleeding from any site, and that can also lead to generalized whole body swelling and then leads to hepatic encephalopathy. There was no any history of fever or sore throat that is associated with the there is no any history of upper respiratory tract infection which can lead to post-streptococcal glomerulonephritis, which is most common cause of nephritic syndrome. There was no any abdominal pain to the patient. If the patient was having massive ascites, then or any peritonitis, then there was possibility of abdominal pain. So no abdominal pain rules out the possibility of peritonitis or any renal vein thrombosis.
Yeah. Dr. Shreya, other participants is also there. So, Chinmay, can you summarize the what are the possibilities, other causes there other than the renal system or this abdomen system?
Sir, what I could gather from the history, OPD and negative history, it looks like I would just like to summarize. Dr. Shreya, please correct me if I'm missing anything. There is whole body edema for 15 days. There is
Yes.
decreased urine output for 10 days. And there is abdominal distension as complained by mother since 10 days. And
Yes.
there was 3 episodes of convulsion one day ago prior to admission at your hospital. And the patient was in full consciousness between the 2 periods of convulsion.
Yes.
Also, there was puffiness of eyes and puffiness of face in the morning, which was more prominent in the morning, and gradually it progressed to upper limbs and then to the lower limbs. Also, you mentioned that there was complaint of passing dark urine. It was 6 to 7 times a day as frequency, and the stream was dark throughout from initiation to the termination. Also, there was no pain while passing urine. Also, you mentioned that the mother complained of complaint of a swelling of external genitalia.
Yes.
From the origin, duration, progression, and negative history, it comes to my mind that probably the pathology could be either limited to the abdomen and also maybe involving CNS. Typically, with the presenting complaint of swelling over face in the morning and progressing downwards, with urinary complaint changes, it hints towards involvement of renal system or urinary tract system. Also, in the negative history, you mentioned that there was no history of burning micturition. There was no urgency, no dribbling of urine, and there was no abdominal pain, which is quite striking. Maybe you may be trying to rule out the pathology in the lower urinary tract infection or something like that. Also, the stream was dark throughout, which is unlikely in the lower respiratory tract pathologies. Also, there was no abdominal pain, which is striking. Could you tell me if there were episodes of vomiting?
There was no any episodes of vomiting or any loose stools.
Suppose, Chinmay, if suppose vomiting is there and this abdomen pain and the loose stools, so what you rule out?
With such complaints such as if the patient had presented with vomiting and loose stool, and if the patient is also presenting with convulsion episode, I would first suspect this electrolytemia secondary to these symptoms.
Any other students wants to reply? Dr. Sapna is there. Dr. Kinnari, please, expert comments from your side. And Dr. Sudhir, welcome, Dr. Sudhir. Yes.
Madam,
Yeah.
you have mute. Kinnari, madam.
Yes,
Yeah.
sorry. So I would just like to stress on how you have taken negative history. So whenever you take history of edema, so there are only three systems that can cause edema, that is cardiac, liver, and renal. So first of all, you should point out that which system you are going to say. So first you have written negative history of liver, then the next comes negative history of cardiac involvement. So it is edema is not due to cardiac dysfunction, that should come first. And now you are like very sure that this edema is because of the kidneys. Then what is the cause of edema? In what is the cause that has kidney damage that has caused edema? So then you need to ask history, like whether there was history of hematuria, rashes, joint pain is there or not. Then that what you have narrated, that the typical edema of renal origin, that has to be very clear in your history. And then comes the complication of nephrotic or nephritic syndrome. So you have ruled out liver, you have ruled out cardiac, then you have said a few things about nephrotic syndrome, then comes nephritic syndrome, and then complication. Now convulsion here is very important finding. And another thing is age, that is very important finding. So so for convulsion, to rule out causes of convulsion, you should know what could be the causes of seizure in a child who has renal involvement. So it could be anything: nephrotic syndrome, complication of nephrotic syndrome, nephritic syndrome, electrolyte imbalance, sometimes CKD, so hypertension. And all these should come into your negative history to pinpoint the diagnosis.
So, ma'am, based on this, what do you suggest? What can be possibilities?
Sorry, I'm not able to hear you.
On the basis of, can you conclude your possibilities? One she cap nephrotic complication.
Yes, so that's
Of renal origin. Complications.
Dr. Poller,
Yes.
the problem is in your this audio there. So echoing is there. So some means maybe you are in the same room or like that. So please make sure that there is no extra voice or noise. Now, okay, Karo. Go ahead. Poller.
Based on history, ma'am, what can you conclude? What can be the possibilities?
Based on the history, there is one possibility of nephrotic syndrome, but there is conversion. So it may be the complication of nephrotic syndrome. The second possibility is nephritic syndrome, and also associated with the conversion. In nephritic syndrome, there will be hypertension is there. So it can be due to conversion can be due to hypertension or any dyselectrolytemia. The third possibility is cerebral and renal vein thrombosis. And the fourth possibility is any metabolic disturbances.
So what kind of metabolic disturbances like you are
It
talking
can
about?
it can be dyselectrolytemia.
Dr. Sudhi, your expert comment, please. Dr. Sudhir.
I think yes, yes.
Okay. Okay, go ahead then the general examination.
Yeah.
Chinmay and other students note down all the findings, and then we have to summarize that finding also, and we will discuss that part also.
After taking informed consent from the mother, patient was examined in supine position in well-ventilated and good light source area. Patient was conscious, well-oriented to time, place, and person. Patient was well-built, well-nourished. On face, on head-to-toe examination, on face there was puffiness and periorbital edema was present. Pitting edema in bilateral upper and lower limb present. Also, there was edema in the back and spinal, paraspinal region edema is present. There was no any pallor, no icterus, no any lymphadenopathy, no cyanosis, no clubbing. Vital parameters. Temperature was 36.6 centigrade by digital thermometer in left axilla. Pulse rate was 114 per minute at left radial artery by palpatory method, regular in rhythm, no any radio-radial or radio-femoral delay. Respiratory rate was 20 per minute, which is regular breathing, and blood pressure was 120 by 84 mmHg, that is more than 99th percentile for age and sex of the child, by palpatory method that was confirmed by the auscultatory method in the right hand in supine position. Anthropometry. Patient was weighing 35 kg, that is in the 90 to 97 percentile for that age. The patient's height was 137 centimeter, that is 90 to 97 percentile for that age. Patient was having BMI of 18.65 kilogram per meter square, that is that was falling between overweight and obesity according to the IAP chart of the girls. This is a growth chart. Now, after the general examination, I'm concluding that the patient was having hypertension and was having a whole body edema, that is pitting in nature. And now I would like to proceeding further for the systemic examination.
Shreya, I would like to ask, how will you explain this anthropometry? So you have said in your history that one child expired due to STEM, and now
Yes.
the other female child has overweight or obesity. How can you explain that?
The weight was slightly overestimated because of edema.
Then what about height?
That was
So the
appropriate.
Yeah, that is most important thing is in these socioeconomic class, they don't know exact age of the child. So maybe child is not 8 years old. So child is now maybe 11 or 12 years old. If child is
Yes.
studying in 4th standard, then at least 10 years old child is
Yes.
there. So if you have a right age, your diagnosis will change completely and your treatment will change totally for nephritic syndrome, for nephrotic syndrome. You
Yes.
know? Okay, go ahead.
Systemic examination. First, I would like to start with the per abdominal examination. The patient was in supine position with the hips and knees flexed. And first, I would like to do inspection. The shape of the abdomen was generalized abdomen enlargement with the bilateral flank fullness was present. Abdominal movement was bilateral symmetrical and thoraco-abdominal type of respiration. The umbilicus was centrally placed, transversely stretched, slightly inverted, and no any discharge or discoloration present. Skin over the abdomen was shiny, stretched, and no any scar present. No any visible pulsation, no any visible peristalsis, any mass or any dilated veins or any localized swelling was present. On palpation, temperature was normal by touch method. On superficial palpation, abdomen was tense, non-tender, no any guarding or no any rigidity was present. In deep palpation, there was no any organ palpable. On percussion, dullness all over the abdomen was present. The Pudel sign was positive. No any shifting dullness or fluid thrill positive. On auscultation, peristaltic sound was 10 per minute. No any arterial bruit or friction sound present. Abdominal girth measurement was 62 cm at the level of umbilicus. On external genitalia examination, vulval edema was present. Now I would like to proceed with the second system which was involved is central nervous system examination. On higher mental function, the patient was awake, conscious, well oriented to time, place, and person. Patient was having intact short-term and long-term memory, normal attention span, right-handedness, insight was present, rapport was normal, patient was having dull mood, and spontaneous speech output, no any abnormality detected. Uh, Cranial nerve examination, olfactory smell sensation was present. On optic nerve examination, gross vision was normal, normal visual field, the color vision present. No any evidence of papilloedema on fundus examination. Pupil was bilaterally equal and reactive to light. Oculomotor nerve is resting eye position bilateral equal and normal. Light reflex was present. Trochlear nerve was able to see downward with adducted eyes. Fifth nerve is trigeminal nerve. The chewing was normal. Corneal and conjunctival reflex was present. Abducent nerve able to see laterally. Seventh, facial nerve examination suggests bilateral symmetrical face movement. Corneal and conjunctival reflex was present. Eighth, vestibulocochlear nerve. The watch test was suggests normal hearing and tandem walking was normal. Ninth, glossopharyngeal nerve. In the taste sensation on the posterior one-third of the tongue was present. Palatal reflex was present. Vagus nerve examination suggests uvula position in the midline. Gag reflex was present. On 11th spinal accessory nerve examination, there was no any shoulder drooping. And hypoglossal nerve examination suggests normal tongue position, normal bulk and size of the tongue. Motor examination inspection suggests there is no any wasting of muscle or no any abnormal posture. Power in the all four limbs suggests 5/5. Tone in the all four limbs normal. Coordination finger nose, finger, heel to knee test. No any abnormalities detected. No any involuntary movements noted. On sensory system examination, superficial touch, pain and temperature was present. On deep sensations, vibration, deep pain, and pressure sensation was present. On cortical sensation examination, tactile localization, 2-point discrimination, and stereognosis present. Reflexes examination suggests superficial reflex, abdominal and plantar reflex was present, and deep tendon reflexes, biceps, triceps, knee, ankle jerk, bilaterally equal and normally present. No any signs of meningeal irritation noted, that is, no any neck stiffness. Kerning sign and Brzezinski signs were negative. Patient can walk in straight line, so the gait was normal. On cardiovascular and cardiovascular system examination, both heart sound present. There is no any murmur on auscultatory finding and no any other significant findings noted. On respiratory system examination, bilateral equal air entry noted. There was no any foreign sounds and no any other significant findings present. So now Chanda is an 8-year-old female who was apparently well till 15 days ago. Then she had history of puffiness around eyes and facial edema progressing to the whole body, and since last 15 days, abdominal distension and decreased urine output for last 10 days, convulsions since last 1 day. There was no history suggestive of congestive cardiac failure or malabsorption or any chronic liver disease. The edema and decreased urine output, hypertension are likely to be renal in origin and complicated by the convulsion. So I would like to investigate the child further with my differential diagnosis, nephrotic syndrome with complication or nephritic syndrome or any dyselectrolytemia or cerebral and renal vein thrombosis. On my course of management, the investigation was done.
Here, can we stop here? And I think Madam has left. Okay, Dr. Palak is there.
Dr. Sudhir is also there. So now, and Dr. Sudhir will discuss the case. And Dr. Palak will further give the information regarding the.
Can anybody explain why child had severe abdominal distension but only puddle sign positive and there was no fluid thrill? Because the AG is 65 centimeter. What could be the reason for that?
Ma'am, that can be just abdominal wall edema.
Yes. So even if that is, you may not find signs of ascites like fluid thrill and further because of the abdominal wall. So Dr. Sudhir, would you like to ask questions?
Okay, ma'am. Thank you.
So, Shreya, what could be the causes of convulsion in a child now? Like you have summarized, most likely it is a nephrotic syndrome or a nephritic syndrome as per your history. So, what could be the causes of convulsion in a child with nephrotic or a nephritic syndrome? And how they
in a nephrotic or nephritic syndrome, there will be electrolyte disturbances.
What kind of electrolyte disturbances will cause seizure in a 10-year-old girl?
that is this generalized whole body edema that is due to renal origin will cause salt and water retention. So that is a hypernatremia can cause seizure, or if it is associated with the nephritic syndrome, then also hypertension can cause convulsion. Also, if a patient was having a kidney injury on the elevated level of urea and creatinine, then also can cause uremic encephalopathy. It may be.
Dr. Chinmay and Dr. Sapna, then you want to add something? And Dr. Chawda is
Good afternoon, sir. I would like to say in complicated nephrotic syndrome, there may be chances of hypercoagulability, which can cause a thromboembolic event and cause seizures in this kind of situation.
1 minute. Dr. Sapna, also the input problem is here. So please correct it. Whether you are sitting with the Dr. Shreya.
Tail is having gradual onset. How you consider nephritic as compared to nephrotic? Any difference? Telling 15 days history is there. It is also less for 10 days. And you are telling BP is only 120/84. It's only 19th centile for the days. Why are you considering nephritic when compared to nephrotic syndrome?
Because in nephrotic syndrome, generally there will be no hypertension, and the patient will be having edema, hematuria, proteinuria, hypertension in nephritic syndrome.
Here hematuria is not there. It is also gradual onset. First point is very gradual onset. For a period of 15 days, it develops. Okay.
Yes, sir.
And compared to nephritis is really sudden onset, as per the history. So in 2 to 3 days, and also you're not are telling about 10 days slowly decreasing.
Yes, sir. Also the age component is there. The patient was almost 8 years of age. The nephrotic syndrome is common in 3 to 6 years of age. After that, there are more chances of nephritic syndrome development.
So it will be toxic when nephritic syndrome and compared to that of nephrotic syndrome. Based on history, we can tell whether it is nephritic or nephrotic. Gradual onset, which is usually progressive in nature. Hypertension may present, your fluid overload may present. That may result in nephritic and nephrotic. Hypertension will be there. But when you take in nephritic syndrome, hypertension will be very severe. Like a hypertension urgency or emergency, they will present. Not like this 120/84. So some other cause we need to rule out for convulsion. Not only the hypertension. Okay.
Okay.
Proceed.
So in my course of management, we have investigated patient. The hemoglobin was 11.1 gram per deciliter. Total count was 14,1500. Platelet was 1.96 lakh. ESR was 48 mm in fast R. Serum creatinine was 1.7 milligram per deciliter. Blood urea was 36. Serum sodium was 144 and serum potassium was 5.2 millimole per liter. Serum albumin was lower side, that is 0.7 gram per deciliter. Serum total cholesterol was 381, which is high. Serum triglyceride was 1036. SGPT was 42. Then HIV, HbSAg and HCV tests were negative. CRP was negative. Urine routine and microscopy suggestive of 5 to 7 RBCs per high power field, and albumin by dipstick method was 4+. USC abdomen suggestive of mild hepatomegaly, minimal ascites with bilateral minimal pleural effusion and bilateral increased kidney cortical echogenicity. Bilateral renal artery Doppler was normal, and urine protein create ratio, that is more 19.95 in 24-hour urine. Patient was started with the IV fluid, antibiotic, IV anti-seizure drug, antihypertensive, oral steroids, and injection albumin after considering nephrotic syndrome as a primary diagnosis. After admission, 4 more episodes of convulsion was present, so further anti-seizure drugs added. For focal convulsion, neuroimaging was done, suggestive of diffuse subcortical hyperintensities involving bilateral frontoparietal and left occipital region, with the possibility of underlying metabolic encephalopathy. Fundus examination, there was no any evidence of papilloedema. For metabolic workup, we have done ABGA that was normal in range. Lactate and ammonia was within normal range. So after all this, we had hematuria, proteinuria, high urine protein create ratio, hypoalbuminemia, hypertension, and altered lipid profile. So the patient was falling into category of nephritic syndrome, nephritis. So further evaluation done, that was suggestive of low C3 and C4 level. It was in the favor of immunological renal disease. So the patient had age of 8 years, female gender, immunological renal disease. ESR was 48 in first hour. ASO titer, CRP, and RA factor was negative, that ruling out the possibility of PSGN. With the suspicion of SLE, we have done ANA, which was strongly positive, and anti-dsDNA antibody was positive. 2D echocardiography was normal. Persistence of urine albumin 4+ and increasing hematuria in serial monitoring, increasing edema, deterioration in the renal function based on oral steroids. So as per nephrologist advice, we have started the patient on immunomodulator and hydroxychloroquine, and for further evaluation and management, patient was referred to the higher center for further management.
Child here has both features of nephritic and nephrotic. Okay, you can't consider acute nephritis. Both features are there. So points for nephrotic are generalized edema, which is gradual in onset, decrease in output gradually, and associated with of hypoalbuminemia, is less than 2.5, and hypercholesterolemia. These points go with nephrotic. Along with the nephritic features, AKI is there, rise in creatinine, hematuria is there, hypertension. Okay. This is a mixed picture of nephritic. Or you can call it as nephritic syndrome with nephrotic brain proteinuria and other associations. That's why, and creatinine is also high. So we need to evaluate for the further workup, whether it was autoimmune. That's what you did. All the complements, both are lower. C3, C4.
Both complement was low. C3 and C4.
Both are low. So what are the conditions as such, both low C3 and C4?
So, for alone C3, there will be C3 induce glomerulonephropathy. And for both C3 and C4, there will be SLE or
three or four conditions are there. Both C3, C4, we need to differentiate with 3 or 4 conditions. Cryoglobulinemia, which we not commonly see in the adults. Okay. Another one is SLE, what you are telling. Another one is MPGN, membranoproliferative glomerulonephritis, the other cause. Another one is shunt nephritis or infective endocarditis. These are the common conditions which are as well both low C3 and C4. Only low C3 is being a lot of bias are there.
What will happen to your complements in PSGN or post-infectious glomerulonephritis?
In that, complements were in normal range.
In post-infectious glomerulonephritis, only C3 will be low and C4 will be most of the time normal. So how we will differentiate whether child has PIGN? Because most of the time when we see AGN, we will be doing ASO and C3 only, right? So when you will evaluate further on the basis of complements?
On the basis of complement, when there is only C3 is low or C3 is normal, then if C3 is low, that uses only classical complement pathway. So the patient will be having, if ASO is increased, then or any history of pharyngitis or skin infection was present, then we will be having PSGN. Or if there was a history of any malar rash or any joint pain present, or any then we'll proceed for anti-DSDN antibody. That was for SLE. And if the patient was having any history of rheumatic heart disease, then we'll proceed for Sudico and for bacterial culture to rule out any infective endocarditis.
So what we generally do is that most of the AGN seen by pediatricians are most common is post-infectious GN. ASO may or may not be positive. And in PIGN, affected pathway is alternate complement pathway, right? So only C3 will be low. And if C3 is low, we are like little assured that this child is most likely having PIGN, and we will not do further workup, right? If that is like a milder variety, not severe nephrotic range protein, then there are indications of biopsy even in PIGN, which will present like RPGN, rapidly progressing glomerulonephritis, right? But if my AGN patient has normal C3, then I'll be worried, okay? And in not alternate complement pathway, that is classical complement pathway, the conditions are enumerated. All of them will have a low C3 and low C4. Okay. So in PIGN, low C3, which will be even lower, like, you will get around 20 of C3 levels if child has presented to you early. In lupus also, you will see very low complement. But there will be other things like, the way you have seen that nephrotic range proteinuria, and child is deteriorating day by day. In your AGN, PIGN patients, they will start improving once you control their salt and fluid, right? And they will start improving. But this child didn't improve. So that is how you have done further workup. So can you tell me, this is the only way you can diagnose lupus, or lupus can present only as nephritis, or there are any other criteria to diagnose lupus?
There are slick criteria to diagnose lupus that includes clinical criteria as well as laboratory criteria. In clinical criteria, the most commonly the patient was having photosensitive malar rash, that is butterfly rash, and also in chronic stage there will be discoid lesion, or the patient may be having serositis, that is involvement of the pleura or um, pleuritis or any peritonitis, or patient may be having sinusitis, that is polyarticular sinusitis. Then patient will be having any CNS manifestations like any seizure or psychosis. There are also renal criteria for lupus nephritis, and patient may be having any hematological abnormalities, that is hemolytic anemia and thrombocytopenia, leukopenia, and
So can you tell me which are the criteria that are present in your patient? Have you made like a SLIC criteria checklist? So generally in all lupus patients, you should have a SLIC criteria and checklist. Then you see that whether it meets or not.
Yes, the definition, there should be at least 4 should be present out of 17 to diagnose the patient as a lupus, and among 4, there must be 1 from the clinical and 1 from the laboratory criteria to be fitted.
Okay. So you have written one immunomodulator that you have given. What you have given to the child?
That is cyclophosphamide.
Chinmay, Dr. Mayank, Dr. Sapna, you want to add something?
Have you looked for the extrarenal manifestations in SLE in this case?
So the patient was having multiple episodes of convulsion,
Okay.
but and also in the investigation there was suggestive of bilateral pleural effusion. So it may be
nephrotic volume.
that may be serositis.
Yeah. Any cutaneous manifestations you find?
No, sir, there was no any cutaneous manifestations.
Hematological.
Sir, initially the patient was having a normal blood picture, that is 11.1 HB and 14,000 total count with 1,96,000 platelet count. So,
For the serial investigations, have you done any serial investigations after convulsions tail is developing recurrently?
Sir, in serial investigation, there was deterioration in the platelet count. Also, there was deterioration in the hemoglobin, but the total count was there in the normal range.
Okay. So hematological parameters are also there in this child. Most important is CNS. Any child having SLE with CNS is very severe. The prognosis is also usually very poor. Very important. The serious manifestation of any SLE. Okay. Also, SLE nephritis per se, child is having nephrotic range proteinuria, initial presenting with AKI. These are also the grave prognostic signs. So, child should be actually active. So, a very active disease. So, we have to treat it very seriously in the initial part. As ma'am is asking, immunomodulator you are using. So, along with immunomodulator, what are you using for suppressive treatment?
So what did you use at that time? Sorry for this interruption.
Cyclophosphamide.
Okay. So can you tell me indications of renal biopsy in acute glomerulonephritis?
Ma'am, any proteinuria with hematuria and progressive deterioration of the renal function, that is the indication of renal biopsy. And before starting of any immunomodulators, renal biopsy is to be done.
So there are set indications given for renal biopsy in acute glomerulonephritis, and that you should know. And definitely before giving definitive treatment, we need to have a kidney biopsy. Why we need to have kidney biopsy in lupus nephritis?
At least to stage the disease.
Why it is important? Why staging is so important?
For involvement of the
how many stages are there? How many stages are there for lupus nephritis?
There are 5 stages.
They are called as class. Class. And why it is important to define that before starting treatment?
Actually, in the class 1, there was no any
yes,
light microscopy changes was not there, but in immunohistochemistry there were changes, minimal change disease in class 1. In class 2,
so that will give you a severity of disease. Apart from all the medical thing also, we need to have a pathological evidence, and that will help us for the further treatment, as well as it has a prognostic value, right? So that is why we need a renal biopsy before starting treatment if possible. But many a times we do start treatment if the condition is very severe and we are not able to do biopsy, right? Dr. Sudhir, you can ask questions. This child, Dr. Sudhir, this child has been referred, I think, to ITDRC, the same child?
Yes, ma'am.
The same patient we talked.
Yeah.
Used any immunosuppressive treatment initially, like steroids?
Sorry, sir.
Steroids. Have you used any steroids?
Yes, sir.
Initially?
Yes, sir. We have given steroids. While suspecting nephrotic syndrome, we have started the patient with the oral steroids, that is 2 mg per kg per day.
But you are telling child is having gross abdominal edema. How come oral steroids will be helpful? Why they didn't help? What is the reason? All you explained also, the reason also. Child is having AKI and also having gross abdominal wall edema, you are telling.
Yes, sir.
Are oral steroids helpful, or you need to give parenteral?
Sir, initially we can give IV methylprednisolone, then that can be followed by oral steroids.
First you need to give IV methylpred. Okay. Any child is having gross abdominal edema, blood circulation will be less. So whatever medicines we give, they won't reach the circulation properly. Only 50% will reach. So better start on the IV methylpred initially. So based on severity, the dose can be titrated. So you are telling here is atypical manifestations, nephrotic also atypical manifestations, and you are suspecting some autoimmune disorder. And child is having also like RPZ reconnaissance, rapidly progressive glomerulonephritis based on your history. Okay, and also kidney failure, everything is there. It happened very fast with hypertension, encephalopathy, hypertension, everything is there. So better to titrate the doses. High dose of methylpred initially, because ma'am is telling, because severity is very high. That's why biopsy also should be done as early as possible once we stabilize the chain. Child is having hypertension, we want to biopsy. Once the child hypertension, everything is controlled, we'll do for the biopsy and we'll severity of disease and also prognosis of the disease. So what is the dose you are given? Methylpred, high dose or low dose you are given? Even only 2 milligram per kg or more dose you are given, pulse therapy like that?
Sir, in 1 to 2 mg per kg per day, MPS.
Later child was referred. Have you given immunomodulator therapy by yourself or it was referred in referral center?
Sir, given at our center first dose by the advice of nephrologist, and then we have referred the patient to higher center.
Can take over, ma'am.
I think that's it, but you should know newer definition of nephrotic syndrome, and the difference is how clinically you will differentiate nephrotic syndrome and nephritic syndrome, and what is the difference between PIGN and RPRS, how clinically it will be different, and laboratory parameters will be different, that you should know, and treatment of nephrotic syndrome recommendation. Then lupus generally, I don't think it is kept as a major case in your pediatric MD exam, but they can go anywhere. Your examiner can go anywhere. If Dr. Uma Nayak is there as your examiner, then you can be asked anything about lupus nephritis. So yes, you need to know all these complement pathways and levels of complement, and a few basics about which other drugs that we use in lupus nephritis or C3G apart from steroids. At least name of these drugs. Okay. I think Dr. Sudhir, we can conclude here as Dr. Baldev Prajapati sir is not there. So general questions are not asked in detail, and both of us are like pediatric nephrologists, so most of the questions were in that direction. But otherwise, yes, you need to know all these edema, pitting, causes of pitting edema, non-pitting edema, and how you will differentiate and all. Those things you should know, and you need to have like the other means practically you need to show how you will check for edema and all.
Ma'am, how was the at your center?
Sorry. So yes, we have done biopsy, and Dr. Sudhir, for your as you are also involved in this case. So biopsy suggests your class 4 and 5 both, and very beautiful spikes are there in biopsy stains, and already one pulse endoxan child has received. So we have given pulse steroid for 5 doses, and then child is on 1 mcg steroid. Child will be due for second endoxan tomorrow. So tomorrow we will give second endoxan, and child will be discharged after that. Yeah.
Yes.
Okay. Thank you so much for inviting us, for me and Dr. Sudhir.
Thank you, ma'am.
Thank you, Dr.
Thank you, sir.
Yes, yes. Thank you, Dr. Sudhir and Dr. Kinnari and Dr. Palak, and congratulations to Dr. Shreya for presenting this case on the Gujarat group, and active participation of Chinmay, Dr. Sapna, and Dr. Chawda. And one Dr. Mayank is there. Mayank, can you please show the case? Mayank is from the PDU? Yeah. Okay. Thank you very much, all of you. And Dr. Sudhir, we miss you in the talk. But anyway, joined.
You also need to prepare, sir. The first time you are attending, you need to prepare, sir.
Okay, thank you very much, everyone. Thank you very much.
Thank you, sir.